Welcome to Roadmap to Residency. Today we're diving into Preventive Cardiology, a high-yield topic on the Step 2 Clinical Knowledge exam. This video focuses on test-taking strategies rather than comprehensive teaching. We'll walk through real question stems showing you exactly how to approach these questions on exam day. Let's get started. By the end of this video, you'll be able to recognize statin indication patterns instantly when you see them in question stems. You'll understand when aspirin is appropriate for primary versus secondary prevention. You'll know exactly when cardiac stress testing is indicated and which type to choose. And you'll be able to use the 10-year cardiovascular risk framework to guide your answer choices. Remember, these skills are about pattern recognition on test day. Every preventive cardiology question on the boards can be broken down using these 4 pillars. First, always identify if this is primary or secondary prevention. Primary means no cardiovascular disease history yet. Secondary means they already have heart disease, stroke, or peripheral artery disease. Second, understand the risk categories. The 10-year risk calculation drives most primary prevention decisions. Knowing these thresholds will help you eliminate wrong answers quickly. These buzzwords are your friends on test day. When you see atherosclerotic cardiovascular disease history, that's automatic high-intensity statin. Low-density lipoprotein at 190 or above, automatic high-intensity statin. Diabetic patients aged 40 to 75 need at least moderate intensity, and anyone with calculated 10-year risk above 7.5% warrants serious statin consideration. Memorize these triggers. Here's your first practice question. Take a moment to read through it carefully. This 52-year-old diabetic man with no cardiovascular history has a low-density lipoprotein of 115. Think about which statin indication group he falls into before we walk through the answer. Let's break this down step by step. First, this is primary prevention because he has no cardiovascular disease history. Next, he has diabetes and is between 40 and 75. His low-density lipoprotein is in the 70 to 189 range. This fits perfectly into the diabetes statin indication group. According to guidelines, diabetic patients in this category need at least moderate intensity statin therapy. High intensity would be reserved for those with additional risk enhancers. The correct answer is C, moderate intensity statin. Now let's tackle aspirin. This is where many test takers make mistakes. Read this question carefully. A 68-year-old woman wants to start aspirin for primary prevention. She has never had a cardiovascular event, but her calculated risk is 12%. What would you recommend? The key insight here is that this is primary prevention, and age matters tremendously. Current guidelines recommend against routine aspirin for primary prevention in adults over 60. Why? Because the bleeding risk outweighs the cardiovascular benefit at this age. For patients 40 to 59, aspirin might be considered if their 10-year risk is 10% or higher and they have low bleeding risk. But at 68, even with elevated risk, aspirin is not recommended. The correct answer is B. These risk assessment pearls are tested frequently. Know the 4 categories. Low risk under 5%, borderline 5 to 7.5, intermediate 7.5 to under 20, and high risk at 20% or above. But also memorize the risk enhancers. Questions love to test whether family history of premature cardiovascular disease, chronic kidney disease, metabolic syndrome, or inflammatory conditions should push someone toward treatment. Now for stress testing. This patient has classic stable angina, exertional chest pressure that resolves with rest. The key finding in the question stem is left bundle branch block on his resting electrocardiogram. What type of stress test would you order? This is a classic board question trap. Students often jump to exercise treadmill testing for stable angina, but the left bundle branch block makes the electrocardiogram uninterpretable during exercise. You cannot assess for ischemic changes when there's already a conduction abnormality. Therefore, this patient needs stress testing with imaging. Since his symptoms are stable, pharmacologic stress with nuclear imaging or echocardiography is appropriate. The answer is C. One more practice question to cement these concepts. This 45-year-old man has a low-density lipoprotein of 210. What's the most appropriate next step? Think about which statin indication group this triggers. This one should be straightforward now. Low-density lipoprotein of 210 is severely elevated. The magic number is 190. Any low-density lipoprotein at or above 190 triggers automatic high-intensity statin therapy, regardless of the patient's calculated 10-year risk. This is one of the 4 major statin benefit groups, along with secondary prevention, diabetes, and elevated calculated risk. Lifestyle alone is insufficient. Moderate intensity doesn't meet the threshold for severely elevated low-density lipoprotein. The correct answer is C, high-intensity statin therapy. Thank you so much for watching. If this video helped you understand preventive cardiology questions better, please hit that like button and subscribe for more board-focused content. For one-on-one tutoring or help with your residency application, check out our expert advisors at roadmaptoresidency.com. We've helped hundreds of students match into their dream programs, and we'd love to help you too. Let's wrap up with the key takeaways. Know the 4 statin benefit groups: secondary prevention, low-density lipoprotein 190 or above, diabetes aged 40 to 75, and elevated 10-year risk. Remember that aspirin for primary prevention is age-dependent, with current guidelines recommending against it in those over 60. For stress testing, always check if the baseline electrocardiogram is interpretable. And always start by identifying primary versus secondary prevention. For more practice, work through the preventive cardiology sections in your question banks. Good luck on your exam.